Welcome back to another exciting episode of Neurovascular-Nugget. Today, Prof. Mansour, we're tackling a really interesting and frankly super practical topic for anyone in the neurovascular space: how we approach subsequent passes during thrombectomy. It's Nugget 21 and it's all about technique switching.
Absolutely, Salma. It's a question we all wrestle with in the angio suite, right? You've done your first pass, maybe it wasn't perfect, and instantly you're thinking, okay, what's my next move? This analysis tries to shed some light on that very critical decision-making process, specifically looking at reperfusion rates when we switch techniques versus sticking with the same one.
Exactly. And it's not just about getting the clot out, but getting it out effectively and quickly. So, let's dive straight into some of the key findings. What did they find regarding that crucial second pass, especially if your first stent retriever pass wasn't successful?
That's a great starting point. The study found something quite interesting. And your decision first, just if your initial thrombectomy pass with a stent retriever wasn't fully successful, switching to a combined technique for the second pass significantly increased the chances of achieving complete reperfusion. And this is key. It was superior to simply repeating another pass with just the stent retriever alone. However, switching to aspiration alone didn't show the same benefit. So the combined approach seems to be the hero here after a failed stent retriever.
That's really insightful. So if your first go with the stent retriever doesn't quite clear things, bringing in that aspiration component to make it a combined technique seems like a better bet than just trying the stent retriever again. What about the flip side? If you started with aspiration and it didn't work out, what's the recommendation for the second pass then?
Another excellent question, and it mirrors the previous finding quite closely. If your first pass with aspiration alone didn't achieve complete reperfusion, again switching to the combined technique for your second pass was associated with a higher chance of complete reperfusion. And just like before, sticking with aspiration alone for the second pass or even switching to a stent retriever alone didn't offer the same benefit. It really highlights the versatility and potential efficacy of the combined approach.
So whether you start with a stent retriever or aspiration, if it's not enough on the first pass, that combined technique keeps coming up as the stronger option for the second. It's almost like the combined technique is the go-to pivot when standalone methods falter early. But what happens if you've done 2 passes and still haven't achieved full reperfusion? This is where it gets really challenging, right? Let's talk about the third pass.
Exactly, Salma. This is where the stakes feel even higher. For the third pass, specifically after 2 failed stent retriever passes, the data suggests that switching to the combined technique was once again associated with significantly higher chances of complete reperfusion. This was compared to switching to aspiration alone or, crucially, just repeating the stent retriever for a third time. It reinforces that idea that after multiple failures with a single technique, introducing the combined approach offers a better shot.
Wow, so it's not just for the second pass, but even after 2 tries with the stent retriever, the combined technique still comes out on top. What if those 2 failed passes were with aspiration alone? Does the same principle apply for the third pass?
Pretty much, yes. After 2 failed aspiration passes, switching to the combined technique for the third pass was again associated with higher chances of complete reperfusion compared to repeating aspiration alone. However, switching to a stent retriever alone in this scenario didn't show a similar benefit. So the combined technique emerges as a robust rescue strategy whether you fail twice with stent retriever or twice with aspiration.
Do you know what happens statistically early or That's a really strong pattern we're seeing. The combined technique seems to be the preferred escalation. But what if you've already been using the combined technique and it hasn't worked for 2 passes? What do you do for the third pass then? Do you switch back to a standalone technique or do you stick with the combined approach?
This is where the findings get particularly interesting and nuanced. If you've had 2 failed passes with the combined technique, switching to aspiration alone for the third pass was actually associated with lower chances of complete reperfusion compared to simply repeating the combined technique. And similar to other scenarios, switching to a stent retriever alone also wasn't associated with a benefit. This suggests that if the combined technique isn't working after 2 tries, you might be better off sticking with it rather than downgrading to aspiration alone. It implies there's a reason the combined technique was chosen initially, and that reason might still hold true.
That's a really important distinction. So it's not just about switching to combined, but also knowing when not to switch away from it. If combined hasn't worked twice, trying aspiration alone seems to be a step backward in terms of reperfusion success. What about overall efficiency? Did they compare how quickly these techniques achieved complete reperfusion?
They did, and this is another piece that supports the combined technique. When they analyzed the first 3 passes, the combined technique generally achieved earlier complete reperfusion compared to aspiration alone. This speaks to its efficiency and ability to clear the vessel more rapidly, which, as we all know, time is brain.
Earlier reperfusion is always the goal, so that's a significant finding. So, to recap so far, combined technique seems to be the optimal pivot when standalone methods fail and it's generally faster. However, there's always a but in these studies, right? What about the actual patient outcomes? Were there differences in functional outcomes based on all this technique switching?
And here's that crucial but you anticipated, Salma. The study found no statistically significant differences in functional outcomes based on any of these technique switching strategies. This is a really important point to highlight because while reperfusion is our immediate goal, functional outcome is the ultimate goal for the patient. It suggests that while we might get better angiographic reperfusion with certain switches, it didn't translate into measurable differences in how patients were doing functionally at discharge or follow-up.
That's a big takeaway, and it leads us directly into the methodological critiques. When we don't see a difference in functional outcomes, it makes us scrutinize the study's design even more. What were some of the limitations they pointed out, Prof. Mansour?
You're spot on. The first and quite frankly most common limitation with these types of real-world observations is that it was a retrospective analysis. This inherently means we're looking back at data that wasn't prospectively collected for this specific question. So there are always lurking biases and confounding factors that we can't fully control for. It makes it harder to establish definitive cause and effect relationships.
Retrospective studies are great for generating hypotheses, but they often leave us wanting more in terms of proving causality, don't they? What else stood out as a limitation?
Another significant point was the lack of central adjudication of angiographic outcomes. This means that the assessment of whether reperfusion was complete or how good it wasn't done by an independent blinded committee. It was likely assessed locally by the operating physician or local site staff. This introduces potential variability and subjective bias in how reperfusion was graded, which could influence the results.
Operator variability, that's a classic. And I imagine that extends to the devices and techniques themselves, right? We're not talking about a perfectly standardized environment here.
Precisely. There was heterogeneity in devices and techniques used between different centers and even different operators within the same center. Think about it, different brands of stent retrievers, various aspiration catheters, differing operator preferences, or even just subtle technique variations. All of this can impact outcomes and make it difficult to attribute success purely to the type of technique switching rather than the specifics of how it was performed or which device was used.
That's a huge factor to consider. It's not just a stent retriever, it's which stent retriever and how was it deployed. And then, of course, there's always the issue of sample size, especially when you start breaking down different failure scenarios and switching strategies.
Absolutely, Salma. The study acknowledged limited sample sizes for some of the more specific technique comparisons. When you're looking at, say, the third pass after 2 failed combined technique passes, the number of patients in those subgroups can become quite small. This makes the statistical power lower and means we should interpret those specific findings with a bit more caution.
Small numbers can really make it tough to draw strong conclusions. And we already touched on this, but it bears repeating. The lack of impact on clinical outcomes. That's a major gap, right?
It truly is. The study did not evaluate the impact of technique switching on long-term clinical outcomes like modified Rankin scale scores at 90 days or other important patient-centered metrics. While achieving higher reperfusion rates is vital, if it doesn't translate into better functional recovery for the patient, then the clinical relevance of that angiographic improvement becomes a bit less clear. It's a missing piece of the puzzle.
So, we have these interesting patterns in reperfusion, but we can't definitively say they make patients better off in the long run, partly due to the limitations you've outlined. Given all that, what are the actionable clinical implications from this Nugget 21 that operators can take to the angio suite?
Despite the limitations, there are some very reasonable takeaways. First, the data strongly suggests that early switching to the combined technique after a failed standalone stent retriever or aspiration pass may improve reperfusion rates. It's not a definitive must-do, but it certainly provides a strong rationale for considering it earlier in the procedure.
So, don't be afraid to escalate to combined if your first or second standalone attempt isn't working.
Precisely. And conversely, repeating the same standalone technique after failed passes may not improve reperfusion as much as that early switching. So if you've done 1 or 2 passes with aspiration alone and it's not working, just doing another aspiration pass might be less effective than incorporating a stent retriever for a combined approach.
That's a good reminder not to get stuck in a rut with one technique if it's clearly not yielding results. And then, the big caveat, more data is needed, right?
Absolutely. The biggest implication is that we need more robust, preferably prospective data to confirm these findings and critically to truly evaluate the impact of technique switching on clinical outcomes. While reperfusion is an important surrogate, ultimately we want to know if these technical changes improve how our patients recover and live their lives after a stroke.
That makes perfect sense. So Neurovascular-Nugget 21 gives us some really strong pointers towards favoring the combined technique as an escalation strategy, especially early on, but also serves as a critical reminder that we're still looking for that definitive link to long-term patient benefit. It's a great piece for informing our immediate decisions while keeping us grounded in the bigger picture.
Couldn't have said it better myself, Salma. It's about optimizing our intraprocedural strategies based on the best available evidence, even while acknowledging its limitations and always pushing for higher quality research to refine our practice further. It's how we keep improving for our patients.
Absolutely, Prof. Mansour. What a fantastic discussion. Thank you for breaking down Nugget 21 so clearly for us. It really does provide practical guidance for those tough intraprocedural decisions.
My pleasure, Salma. Always a joy to discuss these important topics with you and our listeners.
And thank you to all our listeners for tuning in. We hope this episode helps inform your practice and sparks further discussion. Make sure to check out the next Neurovascular Nugget for more insights. Until then, stay safe and keep learning.